Good morning. My name is Dr. Vijay, and I will be presenting first-time symptoms of schizophrenia, supervised under the supervision of Dr. Sarthak Bhandari. So, the first-time symptoms, it was first given by Kurt Schneider, and Kurt Schneider was a German psychiatrist, known largely for his writing on the diagnosis and understanding of schizophrenia, as well as the personality disorder then known as psychopathic personalities. Schneider was born in Kreilsheim, Kingdom of Württemberg, and trained in medicine in Berlin and Tübingen. He was drafted for and completed military service in World War I and later obtained a postgraduate qualification in psychiatry. In 1931, he became the director of German Psychiatric Research Institute in Munich, which was previously founded in by Emil Kraepelin. Disgusted by the developing tide of psychiatric eugenics championed by the Nazi Party, Schneider left the institute but did serve as a doctor for the German armed force during the World War II. After the war, academics who hadn't taken part in the Nazi eugenic policies were appointed to serve in and rebuild Germany's medical institution, and Schneider was given the post of dean in the medical school of Heidelberg University. Schneider kept his post until his retirement in 1955. So the concept and definition: the first-time symptoms deals with the mainly delusion and hallucinations. First-time symptoms were regarded as primary symptoms. Schneider said, from the standpoint of psychopathology, primary symptoms are final and irreducible. According to Jasper, if we try to get some closer understanding of these primary experiences of delusion, we soon find we cannot really appreciate these quite alien modes of experience. They remain largely incomprehensible, unreal, and beyond our understanding. So, introduction: Schneider accepted Kraepelin's system of classification and distinguished between abnormal personalities, abnormal reactions, organic psychosis, and schizophrenia and cyclothymia. He had taken a group of psychotic patients, excluded those with clear organic psychosis, reactive psychosis, obvious cyclothymia, and then performed a statistical analysis of the symptoms of remaining psychotic patients who are presumed to have schizophrenia. In those patients, he termed the most frequent found symptoms as first-time symptoms. As for Schneider, first-time symptoms is mostly found in schizophrenia. So Schneider formulated what he considered to be the pathognomic of first-time symptoms in schizophrenia. There are 11. The first is audible thoughts, voice speaking out of his thoughts aloud, voice arguing, referring to the person in the referring to the patient in the third person, voices commenting on one's action, somatic passivity, experiencing external control body changes, thought withdrawal, thought insertion, thought broadcasting, made volition, made affect, made impulse, and delusion perception. Where have you taken this Schneider formulated what he considered to be testimony? So this is the textbook of references. The first is audible thoughts. In the patient's experience of hearing his own thoughts said out loud, the patient may hear people repeating his thought out loud just after he had thought them, answering his own thought, talking about have said them audibly and saying aloud what he's about to think, so what his thoughts repeat voices. So basically जो भी पर्सन कर रहा है जैसे करने वाला है तो फिर जो वॉइस ही लिसन जैसे मैं whatever he is thinking, but the voice will say him, and he will start feeling the exact same what this voice will be talking to him. And it's उसे ऐसा लगता है कि दोनों ears साथ हैं और it will be has some master process, and उसको लगता है कि this is the third person, not then the voice arguing. The voices heard arguing with each other implies two or more hallucinatory voices quarreling and discussing with each other. The patient usually feature in the third person the content of these arguing voices. It's a classic example of either an angel है either a devil है वो argue कर रहे हैं एक दूसरे से, and the patient will be referred as a third. जैसे for example, if he is watching something, one patient will go look at this skinny, he's so coward, he should be locked up. The other person will argue, no Vijay, he's very good. We shouldn't treat him like this. So it's that classical we see in, pop culture ki argue kar rahe hain, and the patient will be in the third person. Then the third is this is the first person, I am talking, and the third person just say we are talking about you, so you will be the third person. And patient
grammar, first person is I,
yes,
second person is
you, and
third person him.
Yes,
okay,
yeah.
People are talking about
yes,
it is grammar. Grammar means I
yes.
is first person,
Yeah.
I or us. Okay.
Yes.
Second person is we, okay, and the third person is he.
Okay.
People are talking about the third person. Okay.
The third is voices commenting. The hallucinatory voices giving a running commentary on the patient's activity occur and are of first rank. The time sequence of the commentary may be such that it takes part just before, during, or after the patient's activity. The patient does not know his particular perception is unique, that other people does not share his perception experience. The abnormal thing about voices commenting is that they should be experienced as perception and as coming from the outside the self. Means, for example, I am एक जैसे मैं patient हूँ, so मैं जूते पहन रहा हूँ, तो फिर the voice वो बोल रही है विजय ने अब जूते पकड़ लिए हैं, विजय अब जूते देख रहा है, विजय के पैर देखो, they are so dirty. The abnormal thing about this, perception होंगे वो मेरे होंगे, it will be unique to myself, but मुझे ऐसा लगेगा कि ये मेरे नहीं है, किसी और के हैं. And thought withdrawal. Thought withdrawal, it is believed by the patient that his thoughts are in some ways being taken out of his mind. He has some feelings of loss resulting from this process. It may be coupled with other thought passive experience. It means, for example, if I'm a schizophrenic patient, मैं अपनी मॉम के बारे में सोच रहा हूँ, but suddenly ऐसा हो रहा है कि कोई फ्रैनिकल एक वैक्यूम आ जा रहा है, इट्स सकिंग ऑल ऑफ माय थॉट्स, और मेरा दिमाग एम्प्टी है, देयर इज नथिंग देयर, एंड इट विल बी फीजिबल मेरा दिमाग कहाँ गया. So it's called thought withdrawal in that case. Then thought insertion experiences thoughts that do not have a feeling of familiarity of being their own, but the feeling that they have put in their mind without his volition from outside himself. So it means, for example, I'm a patient, I'm watching a beautiful sunset, पर अचानक से एक person मेरे दिमाग में आ जा रहा है. I'm thinking nothing about him, और मुझे ऐसा लग रहा है कि उस person के thoughts, मेरा दिमाग is screen, and उस person के thoughts he is flashing his thoughts in my screen. तो मुझे ऐसा लग रहा है कि मेरे thoughts है ही नहीं, ये इस person के फलाना के किसी person के thoughts हैं सब, or these are not my thoughts. Then thought broadcasting. The patient experiences his thoughts withdrawn from his mind and then in the same way made public and projected over a wide area. The explanation he gives for how this can occur will, as usual for the content of delusion, depend on the background, culture and predominant interest. पेशेंट को ऐसा लगता है कि उसके जो थॉट्स हैं टेप में रील में बन चुके हैं और वो रील सब में बढ़ चुकी है और एक सब में पता चला है वट एवर ही इज थिंकिंग वो सबको पता है एंड ही इज वेरी यू नो यू कैन से कि अब मेरे थॉट्स मेरे नहीं रह गए हैं सबके थॉट्स हैं तो उसको ऐसा लगता है कि ब्रॉडकास्ट हो चुके हैं उसके सारे के सारे थॉट्स हाँ सबको पता चल गया उसके and made volition. The passivity of the volition is the patient feels that it is not his that carried. So it means, for example, I'm holding this paper. This is my hand. तो पेशेंट को ऐसा लगता है कि ये मेरे हैंड है ही नहीं ये कोई एक ऊपर से अलग से एक फोर्स है और ये मेरे हैंड्स को फोर्स कंट्रोल कर रही है और मैं एक कठपुतली की तरह हूँ और मैं कुछ भी कहूँ दीज आर नॉट अंडर माई कंट्रोल दे आर इंडिपेंडेंटली मुझे कुछ भी करो ये मैं कंट्रोल नहीं कर सकता हूँ ये सिर्फ ऊपर वाला जो एलियंस है कोई एक फोर्स है वो कंट्रोल कर नहीं सकता Then the eighth is made affect. Passivity of the emotion occur when the affect that the patient experience does not seem to be him, to be his own. He believes that he has made been feel. तो पेशेंट को ऐसा लगता है कि जैसे मैं रो रहा हूँ पर उसके अंदर एक एंगर होता है कि ये रोना दीज आर नॉट माई इमोशंस ये किसी और के इमोशंस हैं जो मेरे अंदर डाल दी हैं और मेरे को करना पड़ रहा है सब चीजें मेरे है ही नहीं सब चीजें तो पेशेंट को लगता है इफ आई एम हैप्पी आई एम नॉट दीज आर नॉट माई इमोशंस कोई और हैप्पी है वो अपने इमोशंस डाल रहा है सबके सब मेरे है ही नहीं then the ninth is made impulse the patient experience of drive which he feels is alien to carry out some motor activity the impulse may be experienced without the subject carrying out the behavior the action is admitted to be the patient's own but he feels that the impulse that precipitated him into doing it was his own for example I'm the patient और यहाँ पर कोई यूरिन का पड़ा है तो मैं खाने में से डाल देता हूँ तो मेरा एक्सप्लेनेशन ये होता है कि मुझे ऊपर से ऑर्डर आया था मुझे क्या कहते हैं एक्सरे डिपार्टमेंट से ऑर्डर आया था कि ये करना है तो मुझे करना ही पड़ा ये सब चीज मेरे करनी था एक इम्पल्स मैं जब तक करूंगा नहीं मेरे को नहीं लगा तो इट वाज मेड बाय सम दोज थिंग ये मेरा नहीं था and that eighth is somatic passivity is a belief that outside influence are playing on the body it is not the same as hepatic hallucination but it is the delusional belief that the body is being influenced from the outside the self may occur in association with the various somatic hallucination the event is experienced as alien by the patient is in that it is not experienced by the patient as his own but inserted into the self from outside इसका मतलब फॉर एग्जाम्पल पेशेंट खिड़की से नीचे कूदा और उसके नी नी टूट गया उसका तो उसको ऐसा लगता है कि ये जो सनराइज है ये मोदी गवर्नमेंट की भेजी सैटेलाइट की सनराइज है वो मेरे पैर के अंदर आ रही है सनराइज और मुझे फील हो रहा है कि मेरे पैर के अंदर आ रही है और मुझे दर्द इसीलिए हो रहा है कि मेरे पैर के बाहर से निकल रही है तो इट्स अ काइंड ऑफ एलियन थिंग उसको ऐसा लगता है कि ऐसा हो रहा है उसके साथ then is delusional perception the only type of delusion that is regarded as the first rank is a delusion perception a normal perception delusionally interpreted and regarded as being highly significant to the patient this is इसका एग्जांपल एक डॉक्यूमेंटेड केसेस बताता हूँ जैसे पेशेंट ने अपने रूम पे पूरे अपनी जितनी भी विंडोज हैं उनको एक होते हैं ना क्या कहते हैं वुडन उनसे नेल करके सब बंद कर रखे थे और अपनी सारी की सारी जो वॉल्स हैं उनमें स्टोरीज लिखी थी और पोएम्स लिखी थी तो फिर उससे पूछा गया कि तुम ऐसा क्यों कर रहे हो तो वो बोलता था कि रात को जब मैं सोता हूँ कि खिड़कियों से डॉक्टर्स आते हैं और मेरे कान में दे पुट एसिड जिससे मैं सो जाता हूँ मैं उठ नहीं पाता हूँ देन द लव ऑफ माई लाइफ कम इन माई रूम तो उससे मेरे को बात करनी है तो ये इंटरेक्शन करने के लिए मैंने पोएम्स और ये स्टोरीज उससे इंटरेक्ट करने के लिए लिखी है उससे पूछते थे डज इट वर्क कि तुमने क्या कहते हैं पूरा सब चीज अपने विंडोज बंद किए ये काम करता है या काम नहीं करता है तो उसको बताते हैं कि डेल्यूजन इस काइंड ऑफ डेल्यूजन उसको सेंस समझाते हैं कि तुम्हारे ऐसा करने से भी कुछ नहीं हो रहा है, उसको पता है नहीं हो रहा है, देन ऑल्सो ही डज दैट थिंग. So that's kind of a delusional perception in that case. Uh, then, as per Schneider, there were less prominent criteria for the diagnosis of schizophrenia other than the FRS, and he termed them as a second-hand symptom. Those are other hallucination, delusional notions, perplexity, depressed and elated mood, experienced of flattening feeling, other abnormal modes of expression, disorder of speech, and other motor manifestation were known as the third-rank symptoms. The Francis Calvin sort of comprehensive textbook of psychiatry 10th edition. Thank you.
उसमें लिखा है क्या प्लान सेट ऑफ किसी के पास
haptic hallucinations. Haptic hallucinations.
Passively.
Present. Haptic hallucinations. Is a
What is perception? Perception क्या होता है?
so जैसे मेरा सोचने का तरीका, my perception जो भी है.
Perception. It leads to the interpretation of the sensory data. Okay. How we say experience the sensory data, that is perception. You add meaning to it, that is perception. Okay. Like if somebody is speaking Chinese, you don't understand Chinese, you are hearing it, you don't understand anything because you have not assigned a meaning to that sensory data. So whatever sensory data we are getting, on that we apply our past experiences, add meaning to it, and then it gives you a total perception. Okay. For example, there is a snake. That is perception. So there can be a perception false flaw in perception. Somebody identifies a rope as a snake. So sensory data is there. That is problem. Perception can be there without stimulus also. So whatever, for example, hallucination, that is a problem in perception. There is no stimulus, no sensory data, but the brain is experiencing it as a sensory data. Voices he is hearing. It's not his belief. So one is belief. जैसे लोग ना मेरे मन में आवाज आ रही है, तो वो कानों से नहीं सुनाई देती उसको. What is delusion?
Delusion is it's that belief कि उसके उनको कितना भी reason
definition है. You can't make these things. Okay, you can't make these things up. There is a specific definitions for delusion. What is a delusion? What is the hallucination? Okay. If you don't understand that, then whatever you are explaining, that is why there is a your explanation for these things is not like उसको लगता है कि ये जो मैंने जो आपने उसका ना semantic delusional perception का उसे लिखा हुआ उसे लगता है कि ये अगर उसको लगता है तो ये perception नहीं, ये belief. Okay, उसको वो belief is different. Like belief is inherent, जो अंदर होता है belief. Perception जो डेटा आता है, delusional perception जो perception उसको हो रहा है उसका वो उस पर वो delusion करता है. For example, अगर जैसे एक पेशेंट था, कहता है वो मुझे मारना चाहते हैं, तो मुझे नमस्ते, नमस्ते क्या उसका, दैट इज परसेप्शन, उसका इंटरप्रिटेशन गलत है। नमस्ते तो हर कोई करता है, वो कहता है वो नमस्ते कर रहा है मेरे को, वो मुझे मारना चाहता है। ओके, सो दैट इज द delusional perception. Okay, either there is a place in all of these definitions. Second thing is that it is not paternal. Schneider himself has written that first-rank symptoms are not paternal. Over the period of time, people assigned a great deal of value for the first-rank symptoms, and it was somehow that in the first-rank symptoms was schizophrenia. But Schneider himself has said that these are not pneumonic of and we find that these symptoms can occur in organic psychosis also. Okay. So tumors, head injuries, it is not all these explanations that we need to you are explaining them, but because you have not understood clearly, that is the problem. Okay. Hallucinations of also the third person hallucination. Clearly, he feels that two people are talking. Not necessarily about him, but they're talking about third person. Third, like they, like that. Any other questions? Okay. Yes, questions.
परसेप्शन जो है वो आपने सही एक्सप्लेन किया, सर ने ऑलरेडी बोला।
वो जैसे कंट्रोल है, डिलीजन, सोमैटिक पैसिविटी है। सोमैटिक पैसिविटी वॉल्यूशन होता है लाइक विल टू मूव, तो वो इट इज एक्टिंग ऑन दैट। ओके, like he clearly will say that I want to move my hand, I'm not able to move my hand. So that is, he will clearly delineate. Yeah, I did not want to get up and walk there, but the forces, external forces, आपने कठपुतली वाला क्या होता है, delusion of control में somatic passivity और ये सब चीजें आती हैं, तो he clearly defines it to one motor symptoms, motor based. External forces either stopping me from doing something or it is making me do something. Okay. When the thoughts का है, तो he clearly will say that I was thinking and it is gone. तो thought withdrawal explain करना मुश्किल होता है, दूसरा thought ही चला गया। What we see is कि patient बात कर रहा है, बात करते करते blank हो गया, thought block और thought withdrawal। तो क्या थोड़ा मुश्किल होता है, तो वो patient explain करता है कि मैं सोच रहा हूँ तो अचानक से मेरा दिमाग जीरो हो जाता है। Okay, और thought insertion में he clearly says that these thoughts are not me. Okay, I had a patient, he said that I am getting thoughts that I am gay, I am not gay. But these thoughts, they are being inserted into my brain by some external agency. Okay. Whereas he thought broadcast, he says that I haven't told anybody, but my everybody knows what I'm doing. जैसे वो बताया ना कि auditory thoughts, audible thoughts. So sometimes that is seen with क्योंकि मेरे thoughts सब सुन पा रहे हैं, so पता चल रहा है एक तरीका होता है, but sometimes they will give some other explanation. कि satellite से जा रहे हैं, लोगों को पता चल जा रहा है. Sometimes no explanation also, but somehow they know whatever is going on in my mind. But then again, you need a clear example. कौन सा आपका thought था और कौन सा thought उनको पता चल गया, आपको confidence है कि नहीं है. So you have to illusion के criteria. It is a false, firm, fixed belief, unshakable by evidence. To give evidence ऐसा नहीं हो सकता, पर वो sticks to it. So it's more than that. Basics, delusion क्या है, hallucination क्या है, perception क्या है. This you will know, then you will understand that there are number of things. These are different from. ठीक है.
हम काफी बार बोला है, आता नहीं है किसी को. No, sir.
हाँ शिवा क्या है? आपने आईटी वालों को डिस्कस लिखा है इसके लिए कनेक्टर के लिए कनेक्टर सर्वर रहता है ड्राफ्ट करो ठीक है और कॉपी टू प्रिंसिपल that this connector is not working properly despite देखो शिवानी
जी जी सर
ये हमारा काम नहीं है ऐसा करना तुम्हारा काम
हाँ नहीं सर वो तो मैंने उनको बोला कि एक्चुअली सर चेंज भी करवा के पूरा ही लगवाना था
एडजस्ट कर रहे हैं फॉर द टाइम बीइंग इट इज नॉट अ प्रॉब्लम ठीक है ना ये तुम्हारा काम ऐसे ही सुनना ना किसी का काम है
सर अभी भी लोग
बुलवा हुआ तो एक एप्लीकेशन बुलवा दो या तो फिर वहाँ से ठीक है हाँ ठीक करके चले जाते हैं वो उनको बोलो कि परमानेंट कुछ करो रिटर्न एक एप्लीकेशन लिखते हैं कॉपी टू प्रिंसिपल एंड एमएस
Morning everyone. My name is Apurva Gupta and under the guidance of Dr. Astana, I'm going to represent on the topic of etiology of depression. Major depression is a common disorder accounting for more disability than any other disorder worldwide. It is associated with significant morbidity, disability, increased medical comorbidities, and mortality. It is the most significant risk factor for suicide, a leading cause of death worldwide, especially in adolescents, young adults, and elderly. Depression is the major symptomatic disturbance in emotional, motivational, cognitive, and neurovegetative realms, that is somatic symptoms in depression, which includes depressed moods, a feeling of guilt, low self-esteem, worthlessness, and accompanied by high anxiety. A loss of pleasure or anhedonia is considered as hallmark symptom of depressive illness. In fact, the presence of either depressed mood or anhedonia is prerequisite for the diagnosis of depressive episodes. Impairment in cognition, including memory and concentration, are often seen, and other major homeostatic symptoms such as feeding, sleeping, and reproductive drive exhibit some form of disturbance. As per NMHS in India, 1 in 20 people over 18 years of age have ever suffered once in their lifetime from depression, accounting to a total of over 45 million persons in depression in 2021. Major depression affects approximately 8% of men and 15% of women. In 75% cases of depression, disease course is recurrent and manifested as multiple cycles of remission and exacerbation. So what causes depression? These are the 4 factors. First one is genetic factors, which include genes, gene environment interactions. Second is neurobiological factors, which include neurotransmitter system, hormones, and perinatal depression. Third is psychological factors, which include stress and trauma. Fourth is social and environmental factors, which includes adverse life events. So when we move to genetic factors, a number of genetic related factors, genomic regions, polymorphisms, and other related aspects have been examined with respect to depression. Links exist between major histocompatibility complex region genes, as well as various gene polymorphisms and depression. Depression runs in families, a phenomenon implicating both genetic and environmental processes. Risk of developing major depression increases about 2.5 to 3 times for those who have a first degree relative with depression. Life-threatening events increases risk from 5 to 6 times in a few months after the event, and genetic polymorphisms that has been linked to increased risk of depression in response to stress. For example, serotonin system. Now we move to biological perspectives on the etiology of depression, which includes neurotransmitters, hormones with hypothalamic pituitary adrenal axis, gonadal steroids, thyroid hormones, and perinatal depression. First is neurotransmitters. To start with serotonin, evidence from an impressive array of studies supports a prominent role of involvement of CNS serotonin systems in depression. Post-mortem, CSF and neuroendocrine studies demonstrate reduced activity of serotonergic neurons in depressed patients, especially those exposed to early life stress. Low concentration of major metabolite of serotonin are found in CSF of patients who are depressed and with suicidal tendencies. As a compensatory response, there is increased density of 5-HT2 receptors in both blood platelets and brain postmortem tissues of patients with depression. Second is norepinephrine. Norepinephrine containing circuits are also considered to be involved in mood disorders. Moreover, neurochemical and neuroendocrine studies in depressed patients and postmortem findings support the role of norepinephrine dysfunction in depression. Similar to the drugs that increases serotonin availability, norepinephrine reuptake inhibitors such as nortriptyline and reboxetine are effective antidepressants. Third is dopamine. Dopamine is a major neurotransmitter that mediates the ability to experience pleasure. Anhedonia is inability to experience pleasure, which is a cardinal feature for depression. A high rate of depression is seen in patients with Parkinson's disease, that is a disorder characterized by dopamine neuron degeneration. Now we move to hormones. When we go back to physiology of HPA axis, adrenal glucocorticoid secretion via the HPA axis normally influences the body metabolism following a circadian schedule with a surge in early morning. In the normal daily feedback regulation of glucocorticoids, cortisol signals to hypothalamic glucocorticoid receptors to inhibit the release of CRH, which in turn clamps down the pituitary release of ACTH and thus decreases cortisol secretion. So how does hypothalamic pituitary adrenal axis is dysregulated in depression? Depression has been linked with elevated cortisol and related neurohormones. Depressed patients show slower recovery of cortisol levels in response to psychological stress than controls. Elevated basal cortisol levels in both CSF and bloods are found in approximately 2/3 of depressed patients, more frequently in patients suffering from more severe type of depression. Furthermore, patients with disease which results in hypercortisolemia, such as Cushing's syndrome, display many symptoms that are similar to those observed in major depression. Definitive test which is done to test the cortisol dysregulation is dexamethasone suppression test, in which nocturnal dose of a high potency glucocorticoid strong enough to suppress the diurnal morning surge in a cortisol level has been shown repeatedly to fail to suppress the cortisol surge in people with major depressive disorders. Second is gonadal steroids, estrogen and testosterone. Estrogen promotes monoaminergic neurotransmitter functioning. Estrogen receptors are found in key locations of emotional regulations in the areas of hippocampus and amygdala, and thus modulate the effects of estrogen fluctuations in producing depressive symptoms. Estradiol is diminished in depressed women, and estrogen augmentation may enhance the responsiveness to SSRI therapy. For men, an association of depression with lower testosterone levels have been reported. Testosterone gel administered to depressed male patients with poor antidepressant response, which improves depressive symptoms. Thyroid hormone also affect the depression. Thyroid hormone dysregulation conceivably contributes to major depressive disorder. Subclinical hypothyroidism has been associated with depressive symptoms in a geriatric population. Diminished triiodothyronine levels have been detected among the individuals with MDD, and the mechanism of thyroid influence on major depression remains unclear. Next is perinatal depression. Being the offspring of a depressed parent, particularly a depressed mother, is a strong risk factor for depression itself. In recent years, there has been an enormous focus on maternal depression occurring prenatally or postnatally, suspected to be especially disruptive of healthy development in an infant. On the other hand, children of depressed mothers inherit not only genetic predisposition for depression, but also risk factors typically correlated with depression. Those are exposure to stressful conditions throughout their development, marital conflict and instability, maladaptive parenting, parents who beliefs and cognitions expressing negative views on the self, world, and future, and dysfunction coping strategies. Third is psychological factors. Major depressive disorder blurs the line between biological and psychological disorders. One of the striking features of mindset of someone with MDD is the pervasively negative attitude about the present values of life in general and in its particular, and about the prospects for improvement. A pervasive sense of hopelessness undermines motivation, self-attitude, and mood. Fourth is environmental and personal contributors to depression. The role of life events in the cause and process of major depressive disorder has been a point of unresolved contention. A number of studies have shown that onset of mood disorders such as depression is undoubtedly impacted by stressful life events that occur in childhood. Traumatic experiences of childhood are unfortunately prevalent in our society and worldwide, which includes physical abuse, sexual abuse, and neglection, etc. Stress has been mentioned in the literature as a risk factor for poor mental health and has emerged as an important determinant for depression. Stress has been linked to release of inflammatory factors as well as development of depression. Chronic stress can impact the dendrites and synapses of various neurons and may be implicated in pathway leading to MDD. That is, stress may be associated with dysregulation of neuronal and synaptic plasticity. Some people experience major depression after low discernible adversity. Some seems to experience depression following an adverse experience in childhood. These are my references. Alan Taslan, 4th edition book, article of Etiology of Depression, that is genetic and environmental factors by Dr. Radu Savinu, and presentation during Diploma in Community Mental Health course for doctors, Department of Psychiatry, Nimhas Digital Academy. Thank you.
What is etiology?
So etiology represent the cause for something.
What is etiology of, say, malaria?
So it is the sporozoites that
Plasmodium.
yes.
Infection by Plasmodium virus. Your etiology. On pause.
Yes, sir. Yes.
Okay. So you have one etiology for depression.
No, sir.
Basically, we don't know the exact etiology.
Yes.
We don't know the exact etiology. These are all hypotheses.
Yes,
These
sir.
are, what are these? These are associations.
Yes, sir.
That means we can start. Exact etiology. There are
Yes.
many things in your site that you can outdated. For example, reboxetine is not reboxetine is as good as and so noradrenaline is associated with depression, but noradrenergic medication, only noradrenergic medications. Oxetine is there, also do not have, like norepinephrine is not used. Okay. Norepinephrine, you said norepinephrine has action on noradrenaline, but it acts on serotonin.
Yes, sir.
Okay. Yes, it is associated with depression, but therapy of noradrenergic agents. I stand corrected, but to the best of my knowledge, reboxetine exactly had a lot of controversy. It was once given approval, but then it there was some problem in the research. They found out, and reboxetine that much effective as monotherapy can be used for augmentation. Okay. Yes. Testosterone and estrogen in management of depression. This again is correct.
Yes, sir.
we don't use like you may take it from this that you know if there is depression, testosterone, estrogen. So thyroid augmentation we do. That is there. Treatment cases. But again, this is not straightforward. You can say. आप लोग बेसिक टेक्स्ट बुक से देखो कैप्टन से आपने जितना लिखा है उतना बता दो दैट इज सफिशिएंट ओके फॉर एग्जांपल अब इसने पीएचडी की आपने उससे बोल दिया दैट इज हाइपोथेसिस ओके सो लॉट ऑफ वर्क हैज टू बी डन
Yes, sir.
रिसर्च के बहुत से लेवल्स होते हैं पहले जैसे ऐसी रिसर्च करते हैं हम लोग भी यहाँ डी कर रहे हैं पीएचडी कर रहे हैं दैट इज इनिशियल रिसर्च most of that is found later on that it may be proved, it may not be. So somebody was given a dissertation on PhD, so that may not work out. So hypothesis क्या वो नहीं टेक्स्ट बुक में जो आपके है वो over years करके आया so that is you can quote a text book. Okay, PhD dissertation की अगर आप आगे रिसर्च करना चाहते हो और like efficacy of estrogen in depression उसके लिए आप बेसिस बना सकते हो इससे काम हुआ है मैं और काम करना चाहता हूँ अगर आप एमडी करना चाहते हो उसको थीसिस करना चाहते हो ट्रीटमेंट के लिए हम यूज नहीं कर सकते राइट
Yes, sir.
सो इंटरनेट पे आपको बहुत सा डेटा मिल जाएगा टेक्स्ट बुक्स आर द वन टेक्स्ट बुक्स गाइडलाइंस दैट यू कैन ओके रिव्यू आर्टिकल्स इन रिनोन्ड जर्नल्स ये ठीक है इसमें दैट यू कैन फॉलो फॉर दिस लेवल फॉर दिस लेवल and then there is a lot of data on the hypothesis which is not it. Okay, so you have to take that ठीक है आप लोगों के लेवल पे बेसिक टेक्स्ट बुक सिनॉप्सिस भी चल जाएगा ठीक है उसमें से आपको पता होगा ठीक है क्या है ठीक है बीडीएनएफ क्या होता है पता है आपको
Yes, sir. Brain derived native electric
न्यूरोट्रैपिक वो नहीं पता है ओके तो वो उसका रोल प्लास्टिसिटी क्या होती है जैसे पहले था कि न्यूरॉन्स चेंज नहीं करते ओके लाइक दे डोंट चेंज इन ब्रेन डज नॉट चेंज इन स्ट्रक्चर तो मतलब प्लास्टिसिटी नहीं इज लेटर फाउंड आउट दैट इन दैट चेंजेस अकर विद डिप्रेशन उसमें उसका क्या रोल है ओके देयर आर न्यू अपकमिंग थिंग्स both of you presented well you have a lot of confidence but the thing is that जो आपका source हो okay you will be good as your source so one of the main things in picking up your presentations or in picking up your this thing is picking the right source okay then going to the basic questions etiology होती क्या है और डिप्रेशन की etiology पता है हमको नहीं पता है हमको हाइपोथेसिस पता है तो सबसे कॉमन जो हाइपोथेसिस है वो क्या है तो सबसे ज्यादा जो वैलिड हाइपोथेसिस है वो है सेरोटोनिन को लेकर के ना सेरोटोनर्जिक जो होते हैं वो पर अभी उसको भी लेकर के क्वेश्चन मार्क्स कि इट इज नॉट नेसेसरी दैट देयर इज डिक्रीज इन सेरोटोनिन दैट कॉजेस डिप्रेशन इट इज प्रूवन दैट एसएसआरआईज आर इफेक्टिव इन एज एंटीडिप्रेसेंट बट it does not correlate उससे hypothesis ये है कि ब्रेन में serotonin कम हो रहा होगा तब शायद डिप्रेशन but there is upcoming research which says that it is not necessary that serotonin was reduced serotonergic drugs are effective and hypothesis of बोल रहे हैं कि paracetamol is effective in treating fever but that does not mean that brain is deficient in paracetamol है ना there is a different how it acts actually you don't know they are effective but it is not necessary that there is deficiency in serotonin. It may grow up. आपको बाद में जो है you may find out how actually what happens. There are medicines also work in number of ways. That is why many medicines who are like reboxetine, atomoxetine. So on paper they should have treated depression. They did not. There are SSRIs also, good SSRIs. So they so the serotonin is of patient नहीं होता काम ठीक है textbook okay ask them to make some textbook okay textbook से जो है दो and basic things only okay 4-5 slides basic which they understand they should understand delusions hallucinations, what is etiology, how, what in depression, even if they understand that we don't have a fixed etiology in depression. So, for example, stressors, okay,
Yes.
and so this is again no stress. उसमें तो genetic study है कि like double hit. So people, some population is resilient to stress. Okay, उसमें तो कैप्लान सेडॉक में पब्लिश्ड है, उसमें डेटा दे रखा है उसमें कि जिनको चाइल्डहुड अब्यूज हुआ उनमें से भी जिनको 5HT उसमें जीन में पॉलीमॉर्फिज्म था, तो जिनको शॉर्ट एलील था उनको ज्यादा डिप्रेशन हुआ, जिनको दूसरों का उनको नहीं हुआ. तो जेनेटिक प्रीडिस्पोजिशन इज आल्सो नेसेसरी. प्योरली स्ट्रेसर, ओनली स्ट्रेसर, ओनली maladaptive say things cannot be sufficient. Okay, तो ऐसा नहीं कि किसी को अगर कुछ स्ट्रेस हुआ तो उसको डिप्रेशन होगा ही.
Yes, sir.
Similarly, genetic, you said rightly 2.5 to 2.5 times increase होता है, तो वो 100%. मेन में 8% बताया तुमने, और
Yes, sir.
फीमेल में 60. तो अगर 8% है जनरल पॉपुलेशन में, सबको 8% रिस्क. तो अगर किसी का सिबलिंग हुआ तो उसका 2.5 कितना हो जाएगा? 16, 20, 25% हो जाएगा. इट्स नॉट 100%. So while you are telling to your patient, we should be cautious in telling. हाँ, तुम्हारे वो बोलते भी हैं कि सर मेरे भाई को अगर मिलते नहीं जाते थे, हाँ हाँ आपको जो ज्यादा चांसेस. We should tell in complete terms कि है पर इतने ज्यादा भी 100% नहीं.
Yes.
Okay. What I tell is that if it is 25%, but you can't tell that whether you are in 75% or 25%. There is no way to tell.
Yes, sir.
So it is equal.
That's just a probability.
ठीक, okay. Thank you.
Thank you.
पहले भी मैंने कहा you should consult, जैसे किसी फैकल्टी से मिल लो at your level. What is it that you need to do? Basic things. Okay? You collected a lot of data, but basic आपके लेवल पे serotonin, noradrenaline जो है ये बता दोगे आप, और ये कि stressful event से होते, genetics stressful event से it can precipitate, है ना, और multiple episodes में नहीं भी चाहिए होता stress. Okay, it is not necessary. Without stressful event also, MDD can major depressive disorder can. So at a level that much information is okay. And for your level, like only telling like the definition of the first time symptom, you don't expect you to properly explain all the even the GRCs may have difficulty in explaining made affect or made volition. To try to explain, that is a good thing. Just textbook definition is okay. Because I also selected some what is there. Hey, don't go into the main purpose for giving you people this task is that you learn how to work on a small project. Okay, 5-10 minutes presentation and how to present it. That is all. So it is not a half lecture. Okay, you took much pain in that trying to explain all these things. That is good. But sometimes it is like overdoing. है ना? आपसे expected था कि आप first rank symptoms बता के उनके definition बता दो. That is sufficient. कि हाँ, और first rank symptoms psychosis में use है. Nowadays it is not. आजकल पहले था, आज से 30 years back first rank symptoms अगर हो गए तो diagnostic criteria में भी first rank symptoms. इंटरनेशनल क्लासिफिकेशन ऑफ डिजीज में मोर और लेस फर्स्ट रैंक सिम्टम्स भी लिए थे, अब उसने भी छोड़ दिया. अब जो आज की डेट में अगर स्किज़ोफ्रेनिया का क्लासिफिकेशन है उसमें फर्स्ट रैंक सिम्टम्स को आइडेंटिफाई करने का कोई एडिशनल बेनिफिट. सो थर्ड पर्सन हेलुसिनेशंस और कोई और हेलुसिनेशंस, दे हैव इक्वल वेटेज नाउ टुडेस डे. ओके, इन द डायग्नोस्टिक क्राइटेरिया इवन ICD-11 has discarded these things. तो जो पहले होता था बिजार डिल्यूजन, तो फिर वो उसको आइडेंटिफाई करने में दिक्कत होती थी. तो करंटली फर्स्ट रैंक सिम्पटम्स पर से डोंट हैव एडेड वेटेज इन डायग्नोसिस आज की डेट में. ये ओके, पर वी शुड नो हिस्टोरिकली हाँ ये फर्स्ट रैंक सिम्पटम्स क्या होते हैं. ठीक. तुम लोगों ने क्या अटेंड कैसा था? अच्छा था, तुम लोगों की चाय छूट गई है? इसने क्या तुम लोगों ने पल की थी ना उसके बाद में? चलो ठीक, गुड।
Thank you.